Welcome to the workshop, Managing Infections After Transplant and CAR T-Cell Therapy. My name is Michaela O'Brien, and I will be your moderator for this workshop. It's my pleasure today to introduce our speaker, Dr. Gowri. Dr. Gowri is the Medical Director of the Transplant and Oncology Infectious Disease Program at Northside Hospital in Atlanta, Georgia, where she diagnoses and manages infections in cancer and transplant patients. She has been the principal investigator for 11 clinical trials examining new diagnostic methods and therapeutics for infection. Please join me in welcoming Dr. Gowri.
Hi, thank you for giving me the opportunity to speak to all of you today. As Michaela said, my name is Dr. Gowri Satyanarayana, and I'm a transplant infectious diseases physician at Northside Hospital, Atlanta. So the learning objectives of my talk today are the following. For you to recognize some of the common infections that happen after CAR T therapy, autologous transplant, and allogeneic transplant. Understand where these infections come from and learn how these infections are treated. So there's generally 4 categories of infections seen after transplant and CAR T therapy. And these include infections caused by bacteria, viruses, fungus, and parasites. This figure shows when common infections occur after transplant and what specific factors in a patient contribute to the specific infection. Because not every patient will get every infection in this figure or every infection that we talk about today. And this figure is really focused on allogeneic transplant, where in the very top horizontal, there are time points after the transplant, and vertically, there are categories, including immune system deficits, factors related to the transplant, the types of infections, many of which we'll go over today, and then lower incidence infections that might occur. So the first phenomenon that I really wanted to speak to all of you about is what's called a neutropenic fever. A neutropenic fever is often the first sign of an infection in a patient who has undergone CAR T therapy, autologous transplant, or allogeneic transplant. A neutropenic fever occurs in over 80% of patients with blood cancers. Neutrophils, which is where the word neutropenic comes from, are a type of white blood cell that is killed by specific chemotherapies that patients receive. These types of cells, neutrophils, which are types of white blood cells, help control and kill different infections. The neutrophil count decreases to 0 after CAR T therapy, autologous transplant, again, which is cells, your own cells, type of transplant, and allogeneic transplant, transplants using donor cells for several days to weeks. So this is a very specific and fragile time period where patients can be very susceptible to infection. And having a fever can be the only sign of infection during this time. So what can happen during a neutropenic fever? Well, your temperature will go over 100.4, and on your lab work, your neutrophil count will be less than 500. And as I mentioned before, often 0. You might develop chills. You might develop something called rigors, which are shaking chills where you feel cold to the bone. Your blood pressure might drop. You might develop confusion. You might have changes in your breathing. And you may become severely ill, requiring care in the ICU. How is a neutropenic fever treated? Generally, your medical team will have a protocol on how to manage a neutropenic fever. But in general, the following are often done as part of the evaluation for a source of infection causing the fever. And these tests include blood cultures, where your vein is pricked and blood is obtained to send to the lab for cultures, a urine culture, a chest x-ray. Your team might obtain additional scans to look for infection. You'll be started on intravenous antibiotics. Those are antibiotics given through the vein, and these are usually started within an hour of you presenting to the hospital or to the clinic. And sometimes, in addition to antibiotics, an antifungal medication given through a tablet form or through the vein may be given for the infection. So the next category of infection is bacterial infection. And this is a table which shows some of the common sites of bacterial infections and how we diagnose them. Bacterial infections can actually involve a variety of sites within the body, and these infections often come from the normal bacteria living inside of you, which get disrupted by chemotherapy or other medications given at the time of your CAR T therapy, autologous transplant, or allogeneic transplant. These bacteria can also come from outside of you. Bacterial infections can be diagnosed by many different tests, but they often require cultures to identify the specific bacteria. So some of the common sites of infections that bacteria can cause infections are the blood. They can infect your intravenous catheter. They can infect the lungs, which cause a pneumonia. They can infect organs or your colon, areas in your abdomen and pelvis. They can cause urinary tract infections. They can infect the skin and even go to the brain. So this is a table listing different common bacteria which cause infection in the blood that you might encounter. Your team might tell you the name of some or more than one of these bacteria that might have caused an infection in your blood. And these are really common bacteria that cause infection in cancer patients. And in general, we like to categorize bacteria into gram-positive bacteria and gram-negative bacteria. So this is just for your information. If you are ever told that you're infected with any of these bacteria, that you can understand what type of bacteria is this. So just some general sort of statistics. Bacterial infections in the blood impact anywhere from 5 to 10% of autologous transplant patients, 20 to 30% of allogeneic transplant patients. And there's really a wider range in patients who undergo CAR T therapy, but these types of infections in the blood are most common by day 30 after CAR T therapy. So one of the most common bacterial infections that causes diarrhea in cancer patients is a bacteria called Clostridium difficile. This affects anywhere from about 8 to 13% of all transplant patients, with higher rates seen in allogeneic transplant patients, and it This infection usually happens in the first 100 days after transplant. How this infection presents is frequent diarrhea, which we usually think of as 3 or more loose stools in a 24-hour period, abdominal pain, and fever. Your medical team will send a sample of your stool to be tested for the bacteria. That's how the diagnosis of this infection is made. So if any of you listening have actually been diagnosed with Clostridium difficile infection, you might have asked, how did I get this? And we really think there's several factors that contribute to a patient being susceptible to this infection. And that includes receiving chemotherapy, receiving antibiotics in the past, and being in and out of the hospital, because there is a sort of susceptibility of being in the hospital environment, which contributes to the risk of developing C. diff. So all of these factors change your bowel and allow for this bacteria, Clostridium difficile, to grow and cause diarrhea. You can also get this infection more than once. So how is Clostridium difficile treated? You would be given an oral antibiotic that kills the bacteria, and the treatment duration can vary, meaning how long you're treated. Usually the first time is 10 days, but if you have recurrent episodes, you might receive longer treatment courses with antibiotic therapy. There are some patients that have multiple recurrences of Clostridium difficile infection, and by multiple I mean 4, 5. And these patients might be evaluated for something called a fecal transplant, which is a procedure where healthy donor stool is put into your bowel. This would be a procedure that is cleared by and recommended by your transplant team. Your doctor might also put you on a low-dose oral antibiotic to prevent Clostridium difficile if you have had it more than once. So the next category of infections I will talk about are fungal infections. So fungal infections do occur in many cancer patients and patients that undergo CAR T therapy and autologous and allogeneic transplant. So where do fungal infections come from? Well, a variety of places. When we think about fungi, they're generally classified as yeasts or molds. Yeast can be found in different areas, often within your own body, including the gut, the bowel, the urine, skin, nails, and then outside of you as spores in the environment. Molds are most often found in the environment, but can also be found under the nail beds. So, common fungal infections that we can encounter after autologous and allogeneic transplant are shown in this table. Fungal infections are infrequent in CAR T cell recipients. So this is a table which shows some of the common yeasts and molds that can cause infections in our patients. And the yeasts, the most common yeasts are called Candida, and there's another yeast called Cryptococcus, and then molds, Aspergillus and Mucor species. The incidence of fungal infections is less than 2% in autologous recipients and approximately 7% in allogeneic transplant recipients. Patients can develop fungal infections due to different factors, including receiving chemotherapy, which lowers your white blood cell count for extended periods of time, being treated with steroids, which impact the way your immune system functions, and developing something called graft versus host disease after allogeneic transplant, which when treated, the treatments can often weaken the immune system. So overall, patients who develop fungal infections have some change in their immune system, which is predisposing them to develop the fungal infection. So fungal infections are managed in a few ways. For CAR-T, autologous transplant, and allogeneic transplant recipients, they are placed on preventive antifungal medicine to help prevent patients from developing fungal infections. Despite this, patients can still develop fungal infections. Sometimes it's after the preventive medicine has been stopped. Other times, it's even while taking the preventive medicine, because you can develop a fungal infection that is resistant to the preventive medication you've been prescribed. So if you do develop an active fungal infection, that is treated with an antifungal, which is often given in a tablet or through the IV in an intravenous form. There are some fungal infections that can infect the sinus or the lungs or the skin, other tissue sites that require surgery. And again, this would be a treatment recommendation and management done by your transplant team. The next category of infections I'll be speaking about are viral infections. So similarly to fungal infections, some types of viral infections come from within you, while others are spread via contact with other people, usually through respiratory droplets or contaminated stool. So the first group of viral infections I'd like to talk about are called Herpes simplex and varicella zoster. Varicella zoster is also known as shingles. These are common viral infections that can occur after CAR-T therapy, autologous transplant, and allogeneic transplant. Herpes simplex and varicella zoster virus are viruses which are dormant within a patient. This means that the patient was exposed to the infection at some time in the past, and due to changes in the immune system after CAR-T therapy, autologous or allogeneic transplant, the infection comes back. These viruses often cause an infection which look like small blisters filled with fluid. They can cause an infection on the skin, genital area, lips, inside of the mouth, or even infect the brain. A lot of patients who develop these infections on the skin or mouth or genital area describe these lesions are painful. These infections are treated with an antiviral medication, and there are several antiviral medications. Some are available as tablets and others only available through the intravenous route. Most transplant and CAR-T programs will place a patient on medication to prevent these infections. However, patients can still develop herpes simplex and varicella zoster infection despite being on these medications especially if doses of these preventive medications are missed. So the next category type of viral infection is called Cytomegalovirus, or CMV. This is another viral infection that patients can be exposed to before transplant that can reactivate or grow inside of you after CAR T and allogeneic transplant. CMV, or cytomegalovirus infection, is quite rare after autologous transplant. Symptoms of CMV infection can be quite variable and include fever, vomiting, diarrhea, cough, vision changes, and having abnormal lab work, which your transplant and CAR T team would be assessing. The diagnosis is made by a blood test for the virus, which all transplant and CAR T programs should have access to. Interestingly, this virus can also affect organs like the colon, and a biopsy of the tissue can show the virus. Treatment for cytomegalovirus infection is using either a tablet or intravenous antiviral medication. As I mentioned, this type of viral infection is most common after allogeneic transplant, and most transplant centers for the allogeneic transplant patient might place the patient on a preventive antiviral medication. And as I mentioned, the treatment is either an oral or intravenous antiviral to treat an active infection. Respiratory viral infections other than COVID are quite common after CAR T, autologous, or allogeneic transplant. The challenge is that very few of the respiratory viruses that we find on our diagnostic testing have effective treatment. If your medical team suspects that you might have a respiratory viral infection, they will usually try to make the diagnosis by swabbing the nasopharynx, so that would be a swab actually placed inside of your nose, and it goes down to the back of your throat. And the swab is sent for what's called a PCR test. Or you might have a procedure where they actually sample fluid from the lungs, and that fluid is also sent for a PCR test. Some of the most common viral infections that we see that impact the respiratory tract, that's the lungs, are influenza or flu, RSV, respiratory syncytial virus, parainfluenza, and human metapneumovirus. At this time, only influenza has an approved antiviral medication for treatment. The other viral infections do not have any specific approved treatments. Your transplant center might have very individual approaches to some of these infections, which might involve giving you other medications to support you through getting over this infection. The last viral infection I would like to mention is called Norovirus. This is a viral infection which infects the gastrointestinal tract and can cause diarrhea, nausea, vomiting. This is often known as the cruise ship virus infection. Unfortunately, this infection has gone beyond cruise ships and affects our CAR-T, autologous, and allogeneic transplant patients. And this infection can be acquired in the community or in the hospital, and it can actually lead to a chronic diarrhea, most often in allogeneic transplant patients. And when I mean chronic diarrhea, I mean diarrhea that can keep going for beyond 2 or 3 weeks. Unfortunately, at this time, there's no proven treatment for norovirus infection, and your medical team will manage your symptoms of diarrhea, nausea, and vomiting with other medications. The last category of infections I'd like to discuss are what's called parasitic infections. And there's really one main parasite patients should know about, and that is called toxoplasma. This is another infection that patients can be exposed to before transplant, and it can remain dormant or quiet within the body until after transplant, when it can cause an infection in the blood, lungs, or brain. So how do patients get exposed to toxoplasma infection? Generally, the parasite toxoplasma is ingested, eaten, and that can be through undercooked or contaminated meat, contact with contaminated soil, and then coming into contact with contaminated cat feces. So this is often why, for those of you who might have pet cats, your transplant or CAR-T medical team might recommend that you no longer handle the cat litter, because that is a common way this infection is transmitted, is from the cat feces, and you handling the litter and not washing your hands thoroughly, and then ingesting the parasites from your own hands. So the symptoms when this infection is present can involve different areas of the body, and therefore first sign is often actually fever, but patients can also develop headaches or changes in the way they think. The diagnosis for this infection can be done via a blood test for the parasite, a spinal fluid test if your team is concerned that it's infecting the brain, and rarely a brain biopsy is how this infection is diagnosed. And the treatment for toxoplasma infection is via either tablet or an intravenous set of medications, and the treatment can be 6 months or longer. I would like to note that most allogeneic transplant recipients are screened for this infection, meaning your transplant team will do blood work to see if you have evidence of being exposed to this infection before your allogeneic transplant. If there is evidence that your blood work shows that you've been exposed to this infection, you will be placed on a preventive medication after the transplant so this infection does not occur. So this is a slide which goes over a little bit about what we call infection prevention. How can patients and caregivers protect themselves? I would like to preface by saying that you will receive specific guidance and instructions from your transplant and CAR T team. However, the majority of centers will recommend hand washing because strict hand hygiene is very much a bread and butter of infection prevention. Patient and caregiver masking, patient and caregiver vaccination, no gardening, and limiting soil and dust exposure for at least 6 to 12 months after transplant or CAR T therapy. And this is because there are many organisms that you can be exposed to after CAR T or transplant, which can cause an infection in your body because your immune system is not normal. As I mentioned with the prior infection, toxoplasma, no handling of cat litter, and avoiding drinking well water. For those patients who want to travel outside of the U.S. will generally be approved by your individual care team. And many factors go into a patient being approved to travel abroad, which can be actually a little bit more complex depending on any complications you might have after CAR T or transplant. This is just a slide of a sample of the vaccinations which are given after CAR T, autologous, and allogeneic transplant. While these are general guidelines for getting specific vaccines at specific time points after CAR T and transplant, the vaccine schedule is often individualized, meaning it's adjusted for each patient based on if you are receiving additional chemotherapy after CAR T, autologous or allogeneic transplant, and if you also have graft versus host disease after allogeneic transplant. So this schedule, every center has sort of their own little diagram, and your medical team will go over when those start and which ones you're due for. Often the first set of vaccines might be recommended as early as 3 months after your CAR T or autologous transplant and 6 months after your allogeneic transplant. So, just to summarize what I have discussed today, that there are many different infections that can occur after CAR T therapy, autologous transplant, and allogeneic transplant. For many of the common infections that occur in our patients, we do give our patients preventive medications, which we call prophylaxis, to try to prevent the infections. Your education and knowledge about the specific infections and their treatment will help you if you do develop one after your CAR T, autologous, or allogeneic transplant. Those are my references.
Thank you, Dr. Gowri, for this informative presentation. Now is the time that we're going to move. Thank you, Dr. Gowri, for this informative presentation. We'll now move into taking some questions. And if you do have a question for Dr. Gowri, please use the chat box on the lower left-hand side of your screen to submit a question. We'll try to answer as many questions as possible. Okay, our first question is from somebody who keeps getting a cold, and that this has been happening for a year, and nobody is sure what they can do for this. Can you help?
Sure. So as far as this patient who keeps getting a cold for a year, thinking about a case like yours, which I think we do encounter a few patients every year, first and foremost, I hope you have seen an infectious diseases physician, because sometimes it might take another approach, or thinking through the problems about what you're experiencing. What type of cold is it? Has it been diagnosed? Was it a virus? Is this more a pneumonia due to a bacteria? Is it recurrently the same thing? And then, is there anything about your immune system that is not quite normal that is predisposing you to having this recurrent cold? The other comment I would just make is there is also another specialty group of doctors called immunologists that will assess your immune system in more detail to see if there is anything not quite normal with your immune system that is predisposing you to having something like a recurrent cold. And lastly, I would also say that it would be important to make sure it is a recurrent cold, is the actual diagnosis, and that it isn't an alternate diagnosis or another condition that's being missed.
Okay. What are your thoughts about when it's okay to be around pets after CAR T therapy or transplant?
Yeah. So again, this guidance might vary from program to program. However, I think most medical providers in the transplant team would consider dogs to be the pets that are the safest. And generally, after the first 100 days, the 100-day mark is often a good time point to know how well is the transplant working. Have you had any graft versus host disease? This is if you've gotten an allogeneic transplant. And is it safe for you to be, around your pets? In general, I think cats and cat litter are going to be sort of the pet category that's generally not recommended across the board for most patients. And then other pets like birds and lizards are also likely not going to be recommended because it is more for reptiles, organisms that might be on the skin, and then for birds, what is in their poop, basically, that you could inhale and develop infections with. For CAR T and autologous transplant patients, often the day 30 mark is a time point where many assessments are done, and when you will likely get clearance from your CAR T or transplant team that it's okay for you to do certain activities, revisit with your pets, etc.
Okay, this is a question regarding a probiotic Florastor. Saccharomyces boulardii is the yeast. Do you have any strategy to prevent the recurrence of C. diff?
Yeah, so this is a really great question. So there are some transplant programs and CAR T programs that recommend their patients do not use probiotics. And part of the reason there has been some reports of patients developing infections from the organisms in the probiotic. And therefore, the transplant or CAR T centers do not want to put their patients at risk of developing infections from the probiotic. So I would first discuss with your transplant or CAR T medical team what their recommendation is in the general population, and that is patients who have not undergone transplant, CAR T, or received chemotherapy. probiotics are used with a mixed data on that the probiotic helping prevent recurrent C. diff. Part of patients getting over and clearing C. diff, part of it is having an improved immune system to do so. But the other part is also to minimize your exposure to antibiotics, which can redeplete your healthy gut bacteria. Some other things that I would just mention that you could discuss with your transplant or CAR T medical team is eating cultured yogurt or drinking drinks such as kombucha, kefir. Those have live cultures. Also eating sauerkraut, which has good bacteria in it. But I would definitely discuss any and all of those with your medical team to make sure that you're following the guidance that they recommend for their patients.
Okay, what proven treatments have shown the most improvement? After 2.5 years, this patient is still having urinary tract infections.
Mm-hmm. Yes, so this is actually one of the more common issues patients face after CAR T therapy, autologous and allogeneic transplant. So for you as well, I would recommend, if you have not, to see an infectious diseases physician. You may or may not have also seen a urologist, because it does take a bit of a multidisciplinary team to address recurrent UTIs. The first step in assessing recurrent UTIs is it the same bacteria each time, or are there different bacteria causing the UTI each time? Then, are there any issues anatomically or with the urinary system that's predisposing you to developing recurrent urinary tract infections? These could be things like kidney stones, strictures, something called reflux, incomplete bladder emptying. So there are could be different underlying issues that actually predispose patients to recurrent urinary tract infections. And that's where a urologist can help with the evaluation. The other part is if it is the same bacteria causing the urinary tract infection each time, have you received a long enough treatment course to treat the urinary tract infection? Sometimes 2 weeks of antibiotic treatment is not enough and you need a longer treatment course. If all of that has been done and nothing has been found, there are cases where patients will be placed on anywhere from 3 to 6 months of an oral antibiotic to try and see if the urinary tract infection can be prevented. However, for this patient, I would definitely recommend you have an infectious diseases evaluation and also a urologic evaluation if you have not.
Can you discuss some ways to diminish getting respiratory viruses, especially for people who have lung GVHD? And are there some resources to help evaluate what activities they can do or the risk for that?
Sure. So this respiratory viruses for patients who have lung GVHD is actually a really big area of interest and research, because I don't think we really know and understand all of the factors that go into the interplay of how viruses impact the lung function, how much, how well do patients recover. So those are all areas kind of active research. The ways that patients can prevent and sort of protect themselves. So most transplant programs will recommend vaccination for influenza, COVID, and the RSV recommendations have not been finalized yet by our national society, but there will be recommendations for those vaccines for our transplant and CAR T and patients. If a patient is not really a candidate for those vaccines, the medical team will recommend your caregivers and those close to you are vaccinated. Transplant programs will also recommend masking and hand washing. Also recommended will be in the height or peak of these seasons where a lot of these viruses are circulating is that their patients limit how much they're going out into crowds, being around large groups to limit exposure. From an immune system standpoint for respiratory viruses, unfortunately, if you have graft versus host disease, you need the treatment and medications to control the graft versus host disease. So lowering your immune suppression or the amount of medicine suppressing your immune system may not be possible. One strategy some transplant centers take is to measure something called the immunoglobulin level or IgG and give replacement if the IgG level drops. So those are some of the ways that I have seen different centers recommend prevention for respiratory viruses for patients who have GVHD.
Can you speak about the managing of the risk of measles, especially for those who have not yet been vaccinated post-transplant?
Yeah. So this is a great question and a really hot topic right now, given the spread of measles in certain states in the U.S. The issue with the measles vaccine for our CAR T and transplant patients is the measles vaccine is what's called a live virus vaccine. That means there is a live virus material in the actual vaccine, that if you were to receive the vaccine and your immune system is not recovered or still suppressed, you could actually develop a vaccine strain infection from the vaccine. So at this time, for allogeneic transplant patients, the recommendation for the measles vaccine, which is in the form of measles, mumps, and rubella vaccine, is not recommended until after 2 years after transplant. Even after 2 years after transplant, if patients have significant graft versus host disease and are on immune suppression, the measles vaccine is still not recommended. If you've received CAR T or a therapy or autologous transplant and you're still receiving any type of chemotherapy, you're not a candidate for the measles vaccine. So what do patients do? Well, the recommendations at this time are for caregivers and close contacts, if they're candidates, to be vaccinated, to avoid going to areas where the rates are quite high. If a patient is suspected to have measles, this is one of our patients, a transplant or CAR T patient, there will be specific protocols followed by your medical team. Unfortunately, at this time, Yes, you're correct. Because most of our patients are not candidates for the live virus vaccine, we are left kind of mitigating this infection with those around our patients.
What's an effective treatment for toenail fungus after CAR T therapy if there's liver issues?
Yes, this can be a challenge because many of the medications used for toenail fungus, which are oral tablets, are metabolized through the liver. So first, for this patient, I would recommend that one, if we know what exact toenail fungus you have, like someone has actually cultured or identified the strain, it is looked at what all antifungals might kill this and are any less toxic on the liver. If really all of the medications are off the table, one route might be to actually see a podiatrist that is, a doctor who specializes on the feet and therefore also on the toenails of the feet, and see if you are a candidate for any type of toenail removal or cutting down the toenail in any way. Sometimes the podiatrist can also be helpful in getting toenail specimens for culturing, so we can actually identify the exact toenail fungus that we would target with an antifungal medication. I would mention one other thing, sorry, for this patient.
Sure.
There are also topical medications available for toenail fungus, but my sense is you've probably already tried those and they haven't helped. So I'll just stop there for that question.
6 months after a CAR T therapy, this patient got a salmonella infection requiring hospitalization. How did that infection happen?
Yeah. So, it's interesting. Even non-transplant patients or CAR T patients do get salmonella. And what we think is most likely you contracted this infection from eating something that might have been undercooked or contaminated with salmonella. Often we think about eggs, things that come from poultry that are contaminated with salmonella. And we ingest it, and the bacteria can cause a diarrhea. It can also go into the blood, and that infection is treated with antibiotics. So most likely you were exposed to salmonella through something you ate.
This person has water from a well in their home. Are there any options for her?
Yes. So the issue with well water are some of the organisms that can grow and be present in the well water. So many patients that have undergone CAR T therapy or transplant who have only well water do purchase or install some type of filtration system. So that might be the general recommendation from most transplant care teams.
Do you recommend wearing a mask when somebody is on immunosuppressants 3 years after a transplant? They also had pneumonia last year.
Yes, I think most transplant centers would recommend continuing the mask while you are out in public.
Okay, it looks like this is going to be our last question. Do you think IVIG is beneficial? And also, is it possible to get MMR antibodies from IVIG?
Yeah, so great question. So I think the general community does believe and use IVIG in our patients, especially when levels drop low, and what is low can be under 200. And less than 200 in general, and if you have had recurrent infections, less than 400, where patients would get IVIG replacement or infusions. Now, it's possible you might get MMR antibodies through IVIG, but the question would be how effective are those antibodies, and is it enough to really form a protective response? And I think at this point, the transplant community thinks that likely that is not enough to protect a patient against measles, because I'm just not sure it's really possible to quantify the amount of measles antibody that you would be getting from each IVIG infusion. It could actually vary. So that might be issues upon relying on IVIG for protection against anything related to measles, mumps, or rubella.
Well, on behalf of BMT InfoNet and our partners, I'd like to thank Dr. Gowri for her helpful remarks today, and thank you, the audience, for your excellent questions. Please contact BMT InfoNet if we can help you in any way.